I thank Dr. Tan and Flasco for inviting me to do this presentation, and I thank all the participants who are here to learn more about oncology. We need a lot of more of you guys, because the fight against cancer is very, very hard, difficult, challenging, and we need a lot of quality, highly trained, skilled professionals like you. I also thank Dr. Masood, who did a beautiful presentation and emphasized the importance of collaboration between the clinician and pathologist, and that's much more relevant to my area of discussion, malignant hematology. I'm a very good friend with my hematopathologist, and a lot of times when we work together, we just don't do 3 plus 3, we do 3 times 3, which is 9. So when we work together, the diagnosis can be changed. A lot of times that happens when the clinician and pathologist work together, appropriate diagnosis can happen. And getting appropriate diagnosis is the most important part of taking care of cancer patient, and more so on hematologic malignancy, because treatment, prognosis, and outcome is all dependent on the appropriate diagnosis, because unless you establish an appropriate diagnosis, you cannot deliver the right treatment. And you should not hesitate with second opinion, as Dr. Masood brought it up. You don't look small, you look big by considering your colleagues to when you invite them for discussion, so that you can solve a complex problem. All right. So I have been asked to do, hematologic malignancy. It's a pretty boring area. I'm going to talk about a lot of drugs. Please feel free to interrupt and ask questions, and let's try to make this more interaction between you and me and among us, rather than monotonous one-way boring lecture. Okay. So antimetabolites are some of the oldest, drugs is still used in hematologic malignancies. Methotrexate was discovered back in 1950s and 60s. It's still very useful drug for a lot of hematologic malignancies. Cytarabine is a so methotrexate is one of the oldest drugs. It's still very useful. And pralatrexate is a newer cousin of methotrexate, and it is sometimes used for T-cell lymphoma, peripheral T-cell lymphoma. Cytarabine is one of the old drugs that we still use in AML, also known as Ara-C. Fludarabine, used for CLL. Pentostatin and cladribine are very useful drugs for hairy-cell leukemia. And azacitidine and decitabine are used for MDS. So just so you know, the normal color of methotrexate is yellow. A lot of times, we get confused because there has been a lot of patient safety issues with intrathecal methotrexate, because people have injected. They thought they were injecting methotrexate, but they inadvertently injected vincristine, they inadvertently injected bortezomib, and those mistakes were invariably fatal. So even if you know just the color of your drug, sometimes that will help you. Yellow color means if somebody hands you over, hey, inject methotrexate intrathecally, and it's not yellow in color, you tell them this is not methotrexate, at least. So because of this safety issue in my hospital, there is a policy procedure in place. We do not allow methotrexate injection in clinic and in the infusion center area. Methotrexate, IT methotrexate is solely and exclusively used in the intervention radiology area by our intervention radiology colleague. Still we write the chemotherapy order so that there will be no confusion, because intervention radiologists will not have bortezomib or vincristine in their shelf. So they won't make that mistake. So that's one of our policy procedure. I'm not suggesting that's what you should do, but this is one of the confusions for patient safety, because a mistake usually means a death sentence. So I will spend a lot of I mean, actually, I will spend 2 slides on methotrexate because this is an old drug, it's still a golden drug, very useful for a lot of hematologic malignancies, especially treatment of high risk lymphoma and aggressive lymphoma and treatment of ALL. So the mechanism of action of methotrexate is it causes depletion of folic acid in tumor cells. So basically, leukemia and lymphoma cell cannot divide without them getting enough folic acid. But methotrexate inhibits this enzyme called dihydrofolate reductase and deprives the cancer cell, the tumor cell, the leukemia lymphoma cells of essential vitamin folic acid that's needed for their DNA replication. So they cannot multiply, and instead of they die, in presence of methotrexate. So the main route of elimination is renal excretion. So if your patient has decreased creatinine clearance, you should adjust the drug. Otherwise, there is a high risk of methotrexate toxicity. Methotrexate is a very good drug, but it can also kill the patient, if not monitored and if not adjusted for their, the drug has to be personalized depending on their comorbidities, their kidney function. Otherwise, the high dose methotrexate chemotherapy can be very dangerous. One of the properties of the drug is it is known for third spacing. So if your patient has ascites, pleural effusion or pericardial effusion, that has to be drained before the methotrexate is given, because the drug likes to go to the third space and it stays in there. So even after your blood level is down, the level of methotrexate in the third space fluid, like ascitic fluid, it still remains high. And the methotrexate in the ascitic fluid, for example, diffuses back to the blood on a slow basis, and that will expose the patient to a long duration of methotrexate toxicity. So the methotrexate level in the blood could be could be very high for a long time, and that can cause very serious myelotoxicity, and it can also cause mucositis. This is one of the drugs that you can use oral, IV, and intrathecally, and even intrathecal methotrexate sometimes can cause myelosuppression and mucositis, so you have to monitor the patient closely. So methotrexate is a cornerstone of therapy in patients with primary or secondary CNS leukemia and lymphoma. And we use high dose methotrexate for this purpose, and it is defined as anywhere between 2 to 8 grams per meter square IV. And nobody tell you, ask you why you did 2 versus 8, because people have used different doses and the effectiveness are about the same. So I usually make it an average and do like a 3.54 gram per meter square in my practice. But even if you do like just 2 gram, nobody is going to tell you, ask you why you did low dose. It's still a high dose chemotherapy. And this is given at high dose to achieve therapeutic concentration in the cerebrospinal fluid. And aggressive hydration and preparation of the patient is very important. So the aggressive hydration should be started 12 hours before to ensure that the urine pH is more than 7. And this is important to avoid methotrexate induced nephropathy, because methotrexate can precipitate in acidic urine and it can crystallize in the kidneys, and it can cause acute methotrexate nephropathy, and that may not be reversible. And it's a very big problem, because you will not be able to continue the therapy because you just created a problem. So the patient will die from the cancer because you blocked your road by not taking appropriate precautions. So methotrexate levels should be monitored until the level is safe, and leucovorin rescue, which is basically administering high dose folic acid after 24 hours to rescue your normal cells, because when these chemotherapies like methotrexate are not selective, so they deprive the folic acid from the cancer cells, but they also deprive the folic acid from our normal cells like the bone marrow cells, and the oral mucosa and the gastrointestinal mucosa. So if you do not do leucovorin rescue, you can have prolonged myelosuppression, you can have mucositis that can cause severe oral ulcers, painful oral ulcers, and severe diarrhea. Cytarabine is one of the drugs, it's part of the 7+3 regimen that we do in AML. It also works by inhibiting DNA synthesis. It is usually administered as a continuous infusion because the half-life is very short. So it is in the matter of minutes. So if you give somebody bolus, bolus era C, you basically it is metabolized very fast. So you do not expose the cancer cells to a high concentration of era C for a long time. So that's the reason you do continuous infusion. And it can also be part of intrathecal chemotherapy. We call it triple intrathecal chemotherapy when you combine methotrexate, Ara-C, and hydrocortisone together. That's called triple IT chemotherapy. And hydrocytarabine can cause severe myelosuppression. Usually you keep the patient in the hospital after induction of AML until the counts are recovered. And it can cause severe mucositis, and it has CNS side effects. It can cause cerebellar and cerebral dysfunction, slurred speech, ataxia, confusion, and it can sometimes even cause coma. And conjunctivitis, which is a chemical conjunctivitis, is one of the side effects of Ara-C. So you put the patient on cortisone eye drops, usually for about 10 days, to protect them from that side effects. Fludarabine has significant activity against lymphoid malignancies, particularly CLL and non-Hodgkin's lymphoma. Again, works by DNA synthesis inhibition. It can cause myelosuppression, and it can also cause immunosuppression. Fludarabine is known to cause immunosuppression for a long time. Your CD4 cells do not recover for up to a year or sometimes up to 2 years after completion of chemotherapy. Therefore, your patient can be at risk for unusual infections, including pneumocystis carinii pneumonia, and they are also at risk of herpes and fungal infection, and appropriate antimicrobial prophylaxis is indicated. Cladribine and pentostatin both work by DNA synthesis inhibition. They are both very active against an unusual type of indolent leukemia known as hairy cell leukemia. The remission rate from both of these agents are approximately 80%. Usually they both are very, very effective. But if someone asks you what is the drug of choice in hairy cell leukemia, somebody, if it comes in the test or question, then you have to pick cladribine, and I do not know why, but they like to ask this this question very often when you are being tested. Cladribine is the drug of choice, so if there are choices between pentostatin and cladribine, pick cladribine, but they are both very effective therapy, and I use them interchangeably in my practice. And they are also known for myelosuppression and immunosuppression. And just like fludarabine, the immunosuppression can last for several months to a couple of years, and there is risk for these unusual infections, including pneumocystis carinii pneumonia, and appropriate prophylaxis is indicated on these patients. Azacitidine and decitabine are two DNA hypomethylating agents. They can be used for MDS. The the methylation is a process by which the cancer cells, our blood cells become cancer cells in MDS. So the goal is, the mechanism of action of azacitidine and decitabine is to decrease the methylation process, and it is known as hypomethylation. And I have shown you these two graphs here. These are survival curves. The upper curve is a solid green curve, which for patients who are treated with azacitidine, versus the lower orange color dotted lines. Those are patients who received conventional care regimen, basically transfusion support, and erythropoietin therapy and hydroxyurea. So when you compare, you see about 10 months, 9.4 months survival benefit. This is like across all comers, but there are really some people who benefit from these two, these hypomethylating agents, and they, the hypomethylating agents may work for them for a couple of years. So there are variation For some people, the azacitidine decitabine can work for a couple of years and can provide some durable remission, but eventually in MDS, since it is a malignancy, the patient relapse, and the only curative therapy right now, though very toxic, is allogenic bone marrow transplantation, but there is no curative therapy for MDS apart from the bone marrow transplantation at this time. And sometimes azacitidine and decitabine are used to buy time. And if the blast counts are like high, like more than 10% but less than 20%, then sometimes you can use these agents for cytoreduction to prepare the patients for transplant, like a breeze. Sometimes you use these drugs as a breeze to keep the patient alive until they get definitive therapy, which is allogenic bone marrow transplant, which is very toxic and doesn't always work. And the next class of drug is alkylating, called alkylating agents. They work by alkylate, they work by covalently binding with the DNA molecules and damaging them permanently. So, and they are very useful for lymphoid malignancies, and sometimes they are used in multiple myeloma too. Ifosfamide is can be used for salvage regimen in non-Hodgkin's lymphoma. One of the regimens is called ICE regimen, which includes ifosfamide, carboplatin, and etoposide. Bendamustine is another alkylating agent, can be used for CLL, follicular lymphoma, and melphalan is used for multiple myeloma. So these are all summary of the list of alkylating agents. And I will go in little detail about cyclophosphamide, which is the most common agent in the group that we use a lot, and it's almost like a prototype agent, like the side effects are more or less similar, and the mechanism of action and the pharmacokinetics are similar. So it is well absorbed orally, so 90% bioavailability after oral administration, which is very, very close to IV. So you cannot tell the patient that this is just oral cytoxin, it's not going to cause side effects. No, 90% of that drug is going to be absorbed and it can cause problems. So it is metabolized by liver, excreted in urine. Adjustment is needed for renal dysfunction. It has drug-drug interaction with warfarin, and PT-INR should be monitored closely. The toxicity are myelosuppression, nausea, vomiting. It can cause low sodium, so-called euvolemic hyponatremia or SIADH. And one of the unique side effects is bladder toxicity, which can be acute and chronic. Acute is known as hemorrhagic cystitis, and the late is known as bladder contracture fibrosis, and it can even cause bladder cancer. And uroprotection with mesna and intravenous fluid hydration decreases the risk of hemorrhagic cystitis. And it is also carcinogenic, teratogenic, and it can cause infertility, and it is associated with increased risk of second malignancies, AML, MDS, and as I mentioned earlier, bladder cancer. Ifosfamide is used only IV, and clinical pharmacology and toxicity are similar. Vinca alkaloids, they are plant extract, and vincristine is used in ALL and non-Hodgkin's lymphoma. Vinblastine is a part of ABVD regimen in Hodgkin's lymphoma, and they work by inhibiting mitosis in cancer cell. Basically, what they do is they bind with the tubulin molecules, and polymerization of tubulin is needed for the cell division, but they prevent the polymerization and they don't let the cancer cell divide. Okay, that's the mechanism of action. So it is also known as anti-mitotic agent because it affects the metaphase, the cell division, chromosomal division part of the cell cycle. So vinca alkaloids, the vincristine and vinblastine are slightly different. They both are metabolized in liver and excreted in the bile. Dose adjustment needed for hepatic disease. Renal excretion is only marginal, so you don't necessarily have to dose adjust in kidney problems. Okay, so vinca alkaloids and the alkylators like cyclophosphamide, vinca alkaloids, and there is one more group known as anthracyclines. They are both metabolized by liver, and you need dose adjustment for liver disease. Toxicity is peripheral neuropathy, which can be sensory and motor. and you ask the patient for tingling, numbness in the fingers and toes, and they can also have motor neuropathy. And the first sign is like you can lose the ankle, the patellar reflex. So you have to use your hammer to check your patients every visit if they have the patellar reflex intact. Okay, so that's the earliest sign of motor neuropathy, and you don't want to get there before your patient it starts to have. Usually sensory is first followed by motor. So when they start to have tingling, numbness, you will start dose adjustment, and you don't want your patient to get to the motor phase and have them lose the reflexes. Peripheral neuropathy more with vincristine and rare with vinblastine, and as I mentioned, symmetric distal sensory motor neuropathy. They can cause ileus, and usually after like a regimen like a chop that contains vincristine, patient tend to have some constipation. Usually that goes away after the second and third cycles. And this is a potent vesicant, so you want to make sure there is a central line, and extravasation precautions should be taken, because if there is an extravasation, it can cause skin damage and necrosis. Myelosuppression more so with vinblastine, and there is little myelosuppression. Myelosuppression more so with vinblastine. There is a typo, so myelosuppression less with vincristine. So anthracycline comes in various colors and flavors. I haven't tried, so I don't know the flavors, to be honest. But definitely they come in different flavors. As you know, mitoxantrine is blue in color, and rest of them are similar in color. But if you look carefully, they are slightly different. But all of them can change your body secretions. Like for example, mitoxantrine can cause urine and other body secretions, blue or green, and all other agents like doxorubicin, idarubicin, and danirubicin can cause red, orange, or pinkish discoloration to body secretions, usually starting from the day after infusion. So you want to educate your patients and tell them not to be afraid of, tell them that that's not the blood in the urine, that's just the drugs in the urine. Okay. So doxorubicin is used for lymphoma and ALL, and mitoxantrine, danirubicin, and idarubicin are used in AML. Okay. And anthracyclines, the clinical pharmacology, as I mentioned earlier, metabolize in the liver and excreted in the urine, excreted in the bile. So dose adjustment is needed in liver dysfunction. And vinca alkaloids and anthracyclines, those are the main classes of drugs that are metabolized by the liver, and you need to do dose adjustment for liver disease. Okay. Toxicity include myelosuppression, mucositis, alopecia, urine discoloration to various colors depending on the, if it is mitoxantrine it will be blue, if others it could be reddish or pinkish. Cardiotoxicity is dose dependent, and the risk of cardiotoxicity is lower, less than 5% with cumulative dose of 350 milligram per meter square, but the risk goes higher if you exceed 450 milligram per meter square, and the cumulative dose, the risk is 10% or higher at that point. And the risk of cardiomyopathy also depends on various factors, including age. If you are older, the risk is higher. Prior history of coronary artery disease, hypertension, the risk goes up. Radiation to the mediastinum, patients who are breast cancer survivor, down the road they can get lymphoma, and they may get exposed to doxorubicin, and those patients are at high risk, okay, for cardiotoxicity, cardiomyopathy from doxorubicin. And as with vinca alkaloids, all anthracyclines are potent vesicant. They can cause skin damage and tissue necrosis. Anti-tumor antibiotics, bleomycin is it works by inhibition of DNA synthesis. It's part of ABVD chemotherapy in Hodgkin's lymphoma, and it has a unique side effect, which is dose-related pulmonary fibrosis. Pulmonary function should be done at the beginning of the treatment and every 1 to 2 months during therapy. And if the pulmonary function test decreases by 35%, then you should consider stopping the drug. And history of bleomycin therapy should always be disclosed. Okay, you should educate your patients. Even Let's say your patient with Hodgkin's lymphoma is cured and they are going to have a colon surgery 10 years after they are in remission. The anesthesiologist should be made aware of the fact that patient has had history of bleomycin in the past, because when oxygen therapy is given, they can have lung damage because of the oxygen induced free radicals damage to the lung. So this is one of the unique side effects of bleomycin that should be considered even years after they receive ABPD regimen. Okay. Immunotherapy, all these monoclonal antibodies, because the discovery of these drugs are changing the way we manage cancers, and that's true for rituximab, which was approved in late 90s, and now we have many. Rituximab works by binding to CD20 antigen in lymphocytes, and it causes apoptosis of those cells, and it's the prototype monoclonal antibody. And ofatumumab is also CD20 positive, but it binds to a different epitope, and it works in rituximab resistant cases. And daratumumab is a CD38 monoclonal antibody. It is used for the treatment of refractory myeloma alone or in combination with immunomodulatory drug or proteasome inhibitor. It has single agent activity in multiple myeloma. And elotuzumab is an anti-CS1 monoclonal antibody, and it is used for treatment of refractory myeloma, but it does not have single agent activity, and it needs to be used in combination with immunomodulatory drug or proteasome inhibitor. And rituximab is a prototype, so I will spend one slide with it. So as I mentioned, it is a CD20 antibody and used for B-cell non-Hodgkin's lymphoma and B-cell lymphocytic leukemia. It is metabolized and eliminated by reticuloendothelial system. So kidney function, liver function, you don't need to have any dose adjustment, because the macrophage basically eliminate the drug intracellularly by a process known as proteolysis. Okay. One of the dreadful side effects with rituximab is anaphylaxis, but usually, fortunately, that doesn't happen as often. And as you know, we prevent. Everybody gets get steroid, Benadryl, Tylenol to prevent the infusion reactions to begin with. And usually, fortunately, the infusion reactions, usually the symptoms are mild, including fever, hives, and the angioedema, bronchospasm, and anaphylaxis are fortunately very rare. It can cause tumor lysis syndrome, which is a black box warning. It can cause a rare type of brain damage known as progressive multifocal leukoencephalopathy. Actually, this is not the direct effect of the drug. This is caused by a virus known as JC virus. It is also one of the black box warning. And reactivation of hepatitis B. So you want to make sure everybody getting rituximab needs to have hepatitis B serology. And if they have like a core antibody positive, you put them on antiviral therapy until the lymphocytes recover back to normal. And there is also a slight increased risk of infections, but serious infections are pretty rare. Targeted therapy for CML include BCR-ABL tyrosine kinase inhibitor, and this was also one of the when imatinib came to market, it made it to the front page of Time magazine. So it is one of the transformational agents in modern anti-cancer therapy. The second generation TKI, now we have many of them, and the second generation include dasatinib and nilotinib, and the third generation bosutinib and ponatinib. I have one slide on imatinib just to go over. It's almost like a prototype, and all of these agents are slightly different, but mechanism of action is similar. Side effect profile can be slightly different, but overall pharmacokinetics is more or less similar. So they are useful in Philadelphia positive CML or Philadelphia positive ALL, and they all are oral, and the bioavailability is almost 100%. So this is a good news. So that's why they don't need to be given IV. It is metabolized in the liver and excreted in bile. Used with caution in patients with who are taking Coumadin, because it can increase PT-INR, and this should also be used with caution in patients with phenytoin, phenobarbital, and Shenjan's wort, because these agents can enhance the metabolism of imatinib, and can decrease the drug concentration. And similarly, grapefruit juice, which is an enzyme inhibitor, can increase imatinib levels and can cause toxicity. Usually side effects are mild, though this is listed as a moderately emetogenic drug. In my practice, I think the side effects are only mild. It can cause myelosuppression, so you have to watch the CBC counts, especially in the beginning. And some of the side effects are mainly cosmetic, and a lot of female patients, they don't like ankle edema, and they don't like particularly the periorbital edema some of these patients get. And very, very rarely this can cause congestive heart failure or type of cardiomyopathy. And targeted therapy, we have two for a rare type of acute leukemia known as acute promyelocytic leukemia. ATRA and arsenic trioxide, both of them are approved for treatment. Both of these drugs are oral. ATRA is a retinoic acid or vitamin A derivative. And both of these drugs can cause a differentiation syndrome, which is characterized by fever, leukocytosis, shortness of breath, pulmonary infiltrates on chest X-ray, pleuropericardial effusion, and the treatment of differentiation syndrome is steroid. And arsenic trioxide can also cause QT prolongation and can cause a rare type of cardiac arrhythmias known as torsades. And you want to make sure the potassium and magnesium on these patients are adequate, and you want to maintain at least potassium of around 4 and never let them become hypokalemic, and maintain magnesium around 1.8 or higher. Never let them become hypomagnesiemic. And there are more drugs for multiple myeloma nowadays than any other hematologic malignancies. Thalidomide, lenalidomide, and pomalidomide are called immunomodulatory agents. They are also known as biotherapy because they change the, they work on a particular biologic cycles in the cell, in the enzyme system or the cytokine system. And all of these drugs, the immunomodulatory drug, can increase risk of thrombosis, DVT, PE, heart attack, and stroke. So you give them low dose aspirin, baby aspirin for thromboprophylaxis, and it works really well. There was actually a comparison between low molecular weight heparin like Lovenox, daily injection versus aspirin. Lovenox was slightly more effective, but not a whole lot more effective. So that's why in clinical practice, hematologists usually, because baby aspirin is very convenient, doesn't have much side effects, and there is no cumbersome injection every day, so we use aspirin for our practice. And thalidomide has a unique side effects. It can cause peripheral neuropathy. None of the other drugs like lenalidomide and pomalidomide will do peripheral neuropathy. And all of these drugs can cause myelosuppression. And proteasome inhibitors, now we have many of them. The first generation include bortezomib, which is a sub-Q injection. Second generation carfilzomib is IV. And there is now an oral drug called ixazomib, and the unique side effects of bortezomib is peripheral neuropathy, usually sensory motor, painful sensory comes first. Motors are rare, but you have to pay attention. And carfilzomib doesn't do the peripheral neuropathy, and ixazomib does do peripheral neuropathy, but probably not as much as bortezomib. And one of the reasons why standard of care for bortezomib administration is sub-Q nowadays is because compared to IV bortezomib, sub-Q bortezomib, the risk of neuropathy with subcutaneous bortezomib is 50% lower. So that's a big advancement, in prevention of side effects just by changing the, route of administration. So now I have multiple choice questions. Please feel free to stop and ask questions. So I have a question here. So I will do the reading and you do the answer. So it's all your job. I'm just here to, run the slides. So which one of the following is unlikely to have caused the tissue damage here? So doxorubicin, vincristine, mitoxantrone, etoposide. D. Yes. What is the diagnosis here? The slide. It is extravasation leading to tissue necrosis, right? Right. So correct answer is D. Anthracycline and vinca alkaloids are potent vesicant, need central line to administer these agents. Okay. And this is a slide on pleural effusion. Pleural effusion needs to be drained before administration of which one of the drugs? I hear D. Is that right? Okay. So everybody listening to me. That's very encouraging. Correct answer is D. Methotrexate exits slowly from third space fluid collection. Site is pleural effusion. Half-life is prolonged, leading to increased toxicities. Fluid should be drained prior to methotrexate therapy. Treatment with which one of the following agents may have caused the rash here? What is the rash? What is the diagnosis of this rash? What does it look like? I will give you a clue. This is located in only one dermatom in one side of the body from the midline. So I told you the answer. So this is shingles, right? So reactivation of varicose zoster is caused by which one of these following drugs? Which drug caused the zoster or the shingles? Lenalidomide, bortezomib, rituximab, vincristine. I hear B or D? B like in boy? Yeah, that sounds pretty, yeah, I think that's the right answer. Let me try. Okay, the correct answer is B, you're right. Okay, reactivation of herpes zoster can occur while getting treated with proteasome inhibitors such as bortezomib, carfilzomib and ixazomib. Low dose acyclovir or valacyclovir prophylaxis is very, very effective. I have never seen a single patient getting shingles while getting these low dose prophylaxis with antiviral drugs, you know. Which one of the drugs need to be used with caution with Coumadin? Imatinib, cyclophosphamide, ifosfamide, dasatinib, all of the above. All of the above is always the answer whenever, you know, it is in the, you know, it is in there. So you got it. Okay. All of the above drugs can increase PT-INR. Recommend close monitoring of PT-INR after initiation of these agents. Dose adjustment in renal insufficiency is needed for methotrexate, vincristine, doxorubicin, rituximab, all of the above. You're right, I got you. All right. So methotrexate is the answer here, okay? All right, because you know vincristine, I mentioned to you all previously, vinca alkaloids and anthracyclines are metabolized in the liver, excreted in the bile. So here vincristine is an vinca alkaloids, doxorubicin is an anthracycline. So they both are metabolized in the liver and excreted in the bile. So you don't need to dose adjust in renal insufficiency. Rituximab is metabolized in the macrophages, reticuloendothelial system. So it is, the metabolism is independent of liver and kidney function. So methotrexate is the drug, only drug listed here that needs adjustment in renal insufficiency. Okay. Vinca alkaloids and anthracyclines are cleared in the bile and eliminated in the feces, but methotrexate is cleared by kidneys. Okay, which one of the following agents is unlikely to cause the side effects shown? What does this patient have based on the, you know, painful oral ulcers, you know, multiple ulceration, very, very angry looking mucosal damage there. So this is mucositis, right? Oral mucositis. So whenever you have oral mucositis like this, most of these patients also get severe diarrhea, because whatever changes you see in the mouth usually tends to happen throughout the gastrointestinal tract. So they are very, very susceptible to dehydration because it's hard to swallow fluid, and again absorption when your mucosa is like sick like this, you know, cannot happen, so may not be optimal. So usually whenever you see this and patients are dehydrated and have diarrhea, you need to admit these patients for pain management, IV fluid and support until you know, the healing occurs. So, so which one is unlikely to cause mucositis basically here? So what is the answer here? D. Okay. Correct answer is D. Mucositis, painful oral sores and diarrhea can be caused by methotrexate, Ara-C or cytarabine, and anthracycline like doxorubicin. Bortezomib does not cause mucositis. It's a very safe, benign type of drug. Apart from the peripheral neuropathy, it doesn't usually cause serious side effects needing hospitalization. Okay, which one of the agents is unlikely to have caused the reaction shown? What is the diagnosis of this reaction here? Angioedema. Very, very good. All right. So what is the answer? So we have rituximab, ofatumumab, elotuzumab, daratumumab, and vincristine here. Yeah, because the only monoclonal antibody, everything is monoclonal antibody except vincristine here. So the answer is self-explanatory. But so whenever you see MAB, that stands for monoclonal antibody. So that's good. All right. Answer is E. All monoclonals can cause infusion reaction that can range from mild rash, and it can be little severe like hives, and can be more serious like bronchospasm, and rarely angioedema and anaphylaxis. Angioedema is a very, very serious side effect. Whenever you see them, use the EpiPen that you guys have. Don't wait because this can, really limit the airway, and you may not get somebody there right away to do tracheotomy, but this is a very, very serious side effects. And whenever you see something like this, if you use the EpiPen, that could be life-saving. And EpiPen has been, I have found it to be underutilized. A lot of times, you have to use it whenever there is a serious side effect like this one. So I have a question on multiple myeloma supportive care. So I have a 65-year-old man with multiple myeloma who recently started bortezomib, dexamethasone, and lenalidomide, or the VRD regimen. Some people also call it RVD regimen. They are the same. All of the following supportive care are appropriate except, so acyclovir for varicella zoster prophylaxis, aspirin 81 mg daily for thromboprophylaxis, zoledronic acid for prevention of skeletal related events known as bone pain and fractures, and vaccination against varicella zoster. Why not? You want to prevent the diseases by vaccination, right? Excellent. Yes. All right. The answer is D here. Varicella zoster vaccine is live attenuated, and this can really, the virus, live attenuated virus that you inject can really cause disseminated disease on these patients because of their immunocompromised status. So it is contraindicated in patients receiving chemotherapy. Killed vaccines such as influenza, because you have a flu season coming, go back home and immunize all your patients who are eligible for with flu shot. And pneumococcal vaccine and influenza vaccines are safe. Okay. The first line chemotherapy for Hodgkin's lymphoma, ABVD stands for. Okay, I will let you do the reading and pick the answer here. This is easy. I hear C. Even I get confused, so let's look at the answer. Okay. The answer is A. I think for the next few slides, somehow I think I put the answer in A for all the questions. So, all right, dacarbazine. So I discussed about doxorubicin, bleomycin, and vinblastine already. So I'll mention a line here about dacarbazine. Okay. Dacarbazine is an alkylating agent. It is part of ABVD chemotherapy. It is used IV for Hodgkin's lymphoma. And I think dacarbazine used to be, it can be used in melanoma, but nowadays melanoma has such a good immunotherapy. I don't think anybody using dacarbazine, but you may find it in your book. But it can cause myelosuppression and nausea, vomiting are main side effects. It is also an irritant and can cause, extravasation can be serious here. And MOP chemotherapy, MOPP, MOP. Chemotherapy is not preferred first-line therapy for Hodgkin's lymphoma anymore. There is a very interesting historical perspective on this. So this agent, this therapy, combination chemotherapy, ABVD, was discovered by Europeans in the 60s by the doctor from Italy called Dr. Benadonna. So so Hodgkin's lymphoma was very challenging. A lot of people were dying, but all of a sudden he discovered this regimen, and he started to get a lot of high rate of cure. And at the same time there was a race in the United States to find a good regimen, so MOP chemotherapy was started by Dr. DeVita, the guy who wrote the big book on oncology from Yale, and George Canellos was another doctor from US. So those doctors based in NIH, they were working on MOP chemotherapy. So there was a race between, almost like a Russia and United States, trying to go to moon, So there was a race between Europeans and Americans. So though the ABVD chemotherapy was found to be very effective, the doctors here in the United States, always try to prove that MOP is a better therapy, but because we always try to prove other people wrong, right? So there was finally that led to a comparison study. I think CALGB trial comparing MOP and ABVD, and the ABVD was associated with a higher response rate, higher long-term remission and cure, less toxicity, because MOP is notorious for causing infertility, second malignancies, MDS, AML, and ABVD almost doesn't cause any fertility issues. So very good drug, first line chemotherapy for Hodgkin's lymphoma, because Hodgkin's lymphoma commonly happens in young people, so fertility is always an issue. So fortunately ABVD is not associated with fertility issue, and I tell my patients to be on 2 different types of birth control, because there is risk that they can get pregnant during chemotherapy, and that is a separate disaster, right? Okay, CHOP chemotherapy is used for, the options here are non-Hodgkin's lymphoma, B cell and T cell, Hodgkin's, ALL and AML. A, right. I think I have all the answers for A for the next few slides. Sorry about that. Cyclophosphamide, doxorubicin, vincristine and prednisone. CHOP is used for aggressive B cell lymphoma in combination with rituximab, also known as R-CHOP. It can also be used for T cell lymphoma, but without the rituximab. EPOCH chemotherapy is used for aggressive non-Hodgkin's lymphoma, Hodgkin's lymphoma, ALL, AML. I hear A, right? I gave you a clue, all the answers are A. Etoposide, prednisone, vincristine, also known as oncovin. Cyclophosphamide and doxorubicin is used for aggressive B cell non-Hodgkin's lymphoma in combination with rituximab or R-CHOP. This regimen requires the use of prophylactic antibiotics to prevent infectious complications, and also you have to use G-CSF, from the first day after the chemotherapy, end of chemotherapy, until white blood cell count, the absolute neutrophil count is more than 1000. Hypercivat chemotherapy is used for Hodgkin's, AML, MDS, ALL, aggressive B cell non-Hodgkin's lymphoma. Say that again. D? D, that's the right answer. It was an A, right? Okay. The term hyper refers to the hyperfractionated nature of chemotherapy, means you use a smaller dose but you use more frequently, so that you provide continuous dose to the toxicity to the cancer cells, and you also minimize the side effects by administering the dose at a lower dose, but more frequently. And CVAD is the acronym of the drugs used in Part A. So hypercivat has Part A and Part B. So Part A includes cyclophosphamide, vincristine, doxorubicin and dexamethasone, or the CVAD, and the Part B consists of methotrexate and cytarabine. Each part is given up to 4 times, so total of 8 cycles altogether. Each cycle is 2 to 3 weeks apart, but you want to do it as quickly is possible. Whenever the counts are like, back to close to normal, wherever they should be, and whenever your patient is not sick anymore, you want to do it in two weeks. You don't want to do it in 3 weeks. If they are doing okay, you start, because the idea is the cancer doesn't rest. So rituximab is added for CD20 positive leukemia, and BCR-ABL tyrosine kinase inhibitor imatinib are added for Philadelphia positive ALL. Okay. 7+3 in AML includes. This is so simple. I'm tired of talking. I'll let you pick the answer. Almost done, okay? Because you guys are probably fatigued with such a long day. And the lunch is almost there, so don't worry. They are setting it up. So even if I stop it now, you will not be able to eat. Okay. Danarubicin for 7 days and cytarabine for 3 days. Does that sound reasonable? Yes. And cytarabine, how about the other way around? Cytarabine for 7 days and danarubicin for 3 days. How about 7+3 equals 10 days of chemotherapy? That's really funny, right? Doesn't sound like it's reasonable. And the last one, 7+3 equals 10 weeks of hospitalization. Well, it could add up to 10 weeks sometimes, but 4 to 6 weeks is very common after AML induction. So, remember I gave you guys a clue. Which one of them has to be infused continuously? Remember among these two drugs, cytarabine and danarubicin? Continuous, because the half-life is very short. Cytarabine, right? So cytarabine for 7 days and danarubicin for 3 days, okay? I think that's the answer, yes. The name 7+3 comes from the duration of chemotherapy course, which consists of 7 days of standard dose cytarabine and 3 days of anthracycline. Most often danarubicin, but it could also be doxorubicin, idarubicin, or mitoxantrone, depending on your protocol that you are familiar with, or the one that your institution uses the most. Okay, I think this is my last slide. Okay, so bear with me. This is very confusing. Look at the answer first. 28-year-old man with Burkitt's lymphoma is admitted for hyper-CVAD chemotherapy. Which combination of laboratory changes you worry about? So you admitted the patient, you are about to go home, you started the chemotherapy, you order hyper-CVAD, you are nervous, you want to check something, and you want to monitor something on this patient. Because Burkitt's is a very, very aggressive lymphoma, and this is a highly curable disease, and if treated appropriately, and you have a 28-year-old man who has a long life ahead. If managed appropriately, he could get a life. But there is a risk this patient can die tonight if not managed well. So what questions I am asking, with these labs here? Tumor lysis, right? Tumor lysis syndrome, TLS. Okay. C, I hear C. C, okay. Oh boy, somebody is really smart in this room. Answer is C. Tumor lysis syndrome causes high potassium, high LDH, high uric acid, high phosphorus, low calcium, high BUN and creatinine, and it can cause renal failure. Okay, the renal failure may not be reversible. Your patient may end up in dialysis, and you are end up with, asking what to do with the rest of the therapy. So basically, this is a question about what is intracellular and what is extracellular. So whenever you give high-dose chemotherapy to Burkitt's patient, there will be a lot of lysis of the tumor cells, the lymphoma cells. So inside of the lymphoma cells, there is, the intracellular ions are potassium and phosphorus. So your potassium will go up when the cells are broken down, and your phosphorus will go up, and when the phosphorus comes out, phosphorus likes to bind with the free calcium that's in the blood, causing calcium phosphate. So that way it lowers the calcium. And that calcium phosphate can go in and precipitate in the kidneys and cause kidney damage. And when the tumor, the lymphoma cells are lysed, you also release, intracellular LDH and uric acid. And uric acid can cause acute urate nephropathy. So there is a double insult on the kidneys on this patient. The only thing is he is young and you can give as much as fluid you want to this man, he will be okay. Even if you order 250 ml an hour and you recheck the patient in 8 hours, he will be fine. But you have to just take some precaution here, okay? Chemotherapy for a cancer with a high cell turnover rate, especially lymphoma and leukemia, should receive prophylactic allopurinol to inhibit uric acid production. Allopurinol is a xanthine oxidase inhibitor, so it will decrease the production of uric acid, but it does nothing to the already formed uric acid. So if your patient has uric acid of 13, you should still give the patient allopurinol, but the allopurinol is not going to bring the uric acid of 13 down to 3 next day. You have to use rasburicase in that case. Okay, because rasburicase, what it does is it makes the already formed uric acid, free uric acid in the blood soluble so that the patient can urinate it out. So you pee it out, you make it soluble. And IV hydration I cannot overemphasize, and maintaining urine output. Rasburicase is reserved for people with high uric acid despite allopurinol and hydration because it's very expensive. You want to limit the use of drug as much as possible because it's thousands of dollars for one dose. But usually you don't need repeat dose. One dose is usually enough, but usually you can prevent that costly intervention. Okay, thank you very much for your attention.